panel once again for a very interesting and discussion that probably brings a lot of questions to mind as to how to implement. And Dr. Yin made the point that what we need is large-scale improvement in a period of time that's reasonable, so that perhaps if we put a learning health system around a lot of these interventions, perhaps we can achieve the time that we're trying to achieve and make all this happen. But we've also decided that quality is a systems property. And so let's look at some of the systems we have in place which will allow or will not allow some of the interventions that we have so eloquently discussed. Let me give you an example. I'm seen by my internist, who I know for 15 years, with an episode of dizziness or lightheadedness. And the internist says, well, I think you may have a TIA, and therefore I'm sending you to the emergency room. So I go to the emergency room, and I'm seen by an emergency room doc, never to seen by my internist again because he doesn't go to the hospital. And the emergency room doc admits me to a floor where a hospitalist takes care of me, and he decides, or she decides, I need an MRA. So I go for an MRA, and while I'm having my MRA, I have a hypotensive episode. So I'm now sent to the intensivist in the ICU unit, where I need fluids for 24 hours. I'm now better, I go back to the floor, I'm seen by another hospitalist, and then I'm discharged by the discharge planning team, and I go home, and maybe they've communicated, maybe they haven't communicated with my primary care doc. So, how do we get everything that we've trying to accomplish here within a system that does exist? I didn't make this up. This is not an uncommon situation in a hospital, an integrated delivery system of the best kind. So how do we do all this? It's not impossible, but how do we do all this and make this happen in a culturally diverse but health literate manner? Tomorrow. Who wants to take a shot at that?
Yeah, I can start, I think. So what you say happens every day, and that's sort of the system that we have now. And that, in part, when we started Project Red, we did a lot of focus groups and key informant interviews and all, and saw and heard these stories over and over again about how patients would be discharged, and one person came in, I remember, for chest pain, rule of chest pain, was scheduled for a post-discharge stress test. Our hospital is a big place, got scheduled at one place, but it was actually at the other place. Showed up, they said, oh, it's the wrong place, you got to go to the other place. And by the time they got there, it was late, they rescheduled it, and he came back during that week with an MI. There's this, stories of patients who come in for heart failure and are taking their Zestril appropriately. Everything is done perfectly right. The dose is increased. They're discharged on lisinopril. They go home and want to do everything exactly right, and they take both medicines and come back in renal failure. And there's just a long list of stories like this. So the transitions within the hospital, the transitions to the hospital, transitions within the hospital, and the transitions home again are all very, very important and getting more complicated, as you say. The Project Red is really designed to address some of those issues around the discharge information, so that it was very, very clear that at that point 20% of patients who leave the hospital have some sort of adverse event within 20 days in Boston hospitals. That we know that almost 20% of Medicare patients are readmitted within 30 days, and maybe a third of them are ameliorable, where we can reduce that. And I think it's an example of really where we can improve care and lower cost, which is very possible to do. It's not like I talk to the medical students about that, and I say, I'm going to say something that you're not going to really understand, that more is not better necessarily. And it is possible, very possible, to improve. If we do things better, if our systems are better, we can lower cost and improve care at the same time. So Project Go was designed to address some of those things, at least the hospital to home piece of it, so that patients and patient caregivers have the tools necessary to care for themselves at home. And we introduced the post-discharge phone call at that point. And we rapidly realized, our data shows that when we call, and the other thing is the phone call is not a social call. I mean, people are complaining now about they get so many phone calls after they go home from the hospital, so maybe it was what started a bad thing. But I hear our case managers call discharge, because now, of course, there's more payments involved if you do post-discharge follow-up. And so I listen to our case managers, and then, it's more of a social thing. How are you doing, and that sort of thing. But if you read with Cindy, we've developed a Project Red toolkit, and there's a whole chapter on the post-discharge phone call, and it's a thick chapter that is very actionable. It says the pharmacists, they bring the medicines to the phone right now, and let's go through each one. And in that process, we realize there's half the people, there's something that needs to be done to fix the problem. Even people who have had this long, explanation and all that. So the issues with medicines after discharge need to be identified, maybe in that phone call or in the post-discharge visit. But you have to identify things that are the problems, and you need to find actions that you can actually take that could actually impact the less frequent ED visits or rehospitalizations. So that's not so easy to do that. And very few places are doing that level of intervention after hospital. So it's all stuff.
Yes.
Let's pretend that this happened to you at Mass General Hospital in Boston, right? And you have to go home with a prescription. Well, if you want to go to the outpatient pharmacy at Mass General, they would have the ability to look up your EMR. It's not on their system, though. They have to go to a separate system to look it up if they have any questions about lab values or whatever. But if you wanted to go to your local pharmacy because you don't want to wait around at the outpatient pharmacy because that's refills, you don't have to go back to the hospital for refills, you go there and the doctor sends it electronically, and now the pharmacy, your local pharmacy, has no information at all, no way to look up any information. All they have is that prescription that was sent electronically, and it doesn't actually match the system that they have in their pharmacy. So we have so we get transcription. So the pharmacist still has to transcribe what was sent electronically, which is what we were trying to avoid. And so that's where medication errors occur. So once you get the hospital part fixed, then you got to bring it back to the local pharmacy too. So there's still a lot of work to be done.
I think in addition to all of that, hospital discharges are one thing and transitions of care within the hospitals are one thing, but I don't think enough is being done in the emergency department and in urgent care settings. I recently was involved in a project where I was going into urgent care settings and ERs to look at their discharge process and look at the health literacy practices there. And I was really shocked to see it was a very large system in Wisconsin, that in their urgent care centers, there are no discharge instructions. I mean, there's a few quick verbal things. I mean, they tell us people want to get in, they got a problem, they want to get in, they want to get fixed, they want to get out. Okay, they're in a hurry. But they're given prescriptions, they're given after visit instructions, they're given recommendations on who to go see. And this is still on the outpatient area, but yet they have no written discharge instructions. So, it's no wonder that they forget what they have to do. So, and that some of these folks end up back in the hospital. There was one case, actually, in the emergency room where a woman came in for some kind of, I think just like severe constipation and some digestive problems on a Friday, and she was given instructions to go to the drugstore and get Prilosec. She thought it was a prescription. You can get it without a prescription. Her husband went to the pharmacy, went to get a prescription for her. It wasn't there, didn't know what to do, came back home. So she didn't get the medicine. Well, guess what? On Monday, she was back in the ER again. So, I mean, they didn't understand what this medication was that they were supposed to do. They didn't have anything that said, this is an over-the-counter medication. You can go into the pharmacy and pick it up. I mean, we've got to really do more to help people in order to keep them out of the hospital and when they're discharged from other settings, even not to mention the problems with inpatient care.
Yes. First question.
Are we allowed to jump in?
No,
The immediate first portion of this questions, Michelle had raised a lot of issues about implementation.
Please use the microphone.
Cindy, use the microphone.
she was asking whether or not they can address Dr. Yin's questions. She was asking whether the panelists can address Dr. Yin's questions.
I don't know that regarding the labeling standards, I don't know that I have an answer, but I can reaffirm the problem. Because when we were doing the interviews with pharmacists and asking them about their familiarity with USP standards, and they were all supportive of them. I mean, everybody looks at this, when we tell people about this project, everybody looks at this, well, why wouldn't you want to do this? Why wouldn't you want to make a medication label easier to understand? I mean, duh, what's the problem? And then we're looking at this, well, why is nobody, why are very few people doing about it? It's because there's really not an advocacy. There's not a center point for advocacy. So there isn't, other than us, just because we were interested in it, we got a grant, we did the project, but there's no group out there that's taking this on as an issue, and approaching the State Board, the National Association of State Boards of Pharmacy, or, so there's really nobody to take this on. Everybody's got all these other issues that they're working on, and so we don't really have an advocate to take this on, is part of the problem.
Yeah, Michelle had asked me about barriers to adoption and that sort of thing. And when I first presented this years ago, to the senior management group of our hospital, the chief financial officer raised his hand and said, let me get this straight. This project decreases ED visits and decreases rehospitalizations. Tell me why this is a good thing. And that, hospitals like ours are sort of on the margin. If 25% of people are readmitted, and if you decrease that by 12%, by half, then that makes a real difference in the bottom line. And as long as we're in the fee-for-service system, even though there are these penalties, the penalties aren't nearly big enough to make up for the difference in decreasing hospitalization rates significantly. So there's really not a lot of effort happening in a lot of places. A lot of places tell me as we go around the country talking to various hospitals that we want to know how to decrease readmissions, but we want to be able to flip the switch when the time comes to really have to be able to do that. And specific to Project Red, I think implementation with EMR is a really big deal. And why Cerner and why Epic have not taken this on, I don't know. We're an Epic hospital, and the Epic people are representing Epic here at all. But the discharge materials are not a whole lot better than they ever have been before. And that there are lots of various kinds of programs that are out there now that could be integrated into Epic to produce patient-centered, health-literate documents in color and icons and various things like that that could be, that are out there to do. And why they don't do that, I don't know exactly. But the implementation is something that, for Project Red, exactly, for a nurse to then reduplicate the data entry to produce the after-hospital care form is not efficient. So it's really about efficiency and implementation now, not so much about do we know what to do to decrease readmissions. I think we know a lot about that, but it's about efficiency and implementation in hospitals.
Yes.
So, great panel, thank you. I do have a bit of... Oh, my name, I'm sorry. Mike Wolf, Northwestern University, member of the IOM Roundtable. I feel a little bit of deja vu to the decade ago meeting that we started talking about some of the drug labeling work. And I'm sure at that meeting, for those people for Dan Morrow and Michael Wohlgalter and other people, probably felt that was a moment of, wow, deja vu, that, many, decade plus before that, they were working on the same thing. And so you do kind of get this feeling of trudging through a very thick swamp. God forbid I'm going to have a lot of these weird terms that I don't, yeah.
Current terminology.
I know, it's very hard terminology, but, I'll be able to throw another one out in a moment, but it really what is kind of, beyond just you want to be able to figure out how do you not impact workflow, how do you increase efficiency, how do you create a business case for making sure that this is something that can actually reduce costs, it's cost savings, or actually can enhance the health system in other ways. If it's a patient safety issue, if you get ahead of a mandate. We've heard all these things from industry and health systems in terms of what's going to make something stick and be scalable and stick. I will say, Dr. Lee, I remember meeting you, Charles, like a decade ago before the last audio meeting, so it's fantastic when I see these little notifications, because I do think Polyglot's really starting to, it is actually a big deal. Obviously, Project Red, and there's so many initiatives, that have started to really show promise in terms of kind of sticking around. But it's the policy piece that, and I was going to mention this at the end when I'm talking, but this notion that we do need to get ourselves out of the way a little bit, in that I feel like a lot of things that continue to trudge through, whether it be in regulatory agencies or organizations that have influence, even on our ability to agree on what are the standards of what a good drug label would look like. How much evidence base do you actually have to have before you can allow the ability to be able to go forth and launch something? That to me is really what is my hope, that we'll be able to get ourselves out of the way and allow us to innovate and to take chances and to say, let's not be so risk averse when we know that a lot of what we currently do right now, a lot of our practices are harmful, and that evidence has shown it, that people are misinterpreting, making mistakes, having impacts on their behaviors. So, again, maybe with our President-elect in his comment, what he said to people in Michigan, what do you got to lose, to a group of disenfranchised people? Maybe we all have to allow ourselves to have good evaluations on the post-launch side. So I don't know, what you have to say, maybe Charles or Brian, in terms of, once you have launched these things and had commercial success with programs, are there continual evaluations in place to show that these things, that there is constant improvement, that you are constantly tweaking these things, you're getting evidence back to show how these can be approved and launched, and at the same time be modified as necessary, so we don't feel like we want to wait until we have 200% of evidence to do something?
Yeah, and I don't want to sound grim here, but I'm getting older and I have this sense of mortality and I want to get things done. But I think this all starts with leadership, okay? And what I mean by that is, about 10 years ago, I approached a major medical center, director of inpatient pharmacy. I showed him our tool about the medication adherence stuff. And after an hour, he said, yeah, that's nice, but it's not my responsibility. And, if the patient came back, the hospital made more money. So I think with the realization that, penalization for readmissions makes them think that, yeah, maybe I should start paying attention to if my patients actually understand before they leave. And to Michael's point, to me, this is just common sense, and it's the right thing to do, but it's surprising how the right thing to do doesn't get people to move. It's got to hit their bottom line. It's got to, affect their HCAP scores. It's got to affect their penalties. It's got to increase revenue, because if they just see this as work and expense, then they won't do it. And getting the users and the pharmacists and the physicians in line has to come from the top down. And regulatory pressure helps a little bit too. To give an example, in terms of the scalability, I'm not naming names just to name names, but Express Script is using our tool, Hyatt is using our tool, Kroger supermarket pharmacies, and probably the biggest healthcare system is Dignity Health. I don't know if you guys know Dignity Health. It's the biggest nonprofit hospital organization in California. They have 37 hospitals. So the way this is going to be integrated, they have a Cerner system, is that they actually track the preferred language upon admission, and at discharge, they'll automatically send the medication list, and we're going to give them the medication list in their language automatically upon discharge. So this is the beauty of IT in terms of scalability, is that if you integrate appropriately and we can get the appropriate medication list post-reconcile, you can scale these solutions. And in terms of the best practice that we saw was not necessarily just nursing, just giving this out, but a clinical pharmacist helping with the reconciliation process, making sure that all the meds are appropriate, and then printing out our document and talking through it and walking them through that process is critical to this process. And San Francisco General did a pilot study with our tool, and they had a clinical pharmacist compared to traditional nursing education, and their readmission rate went from 26% to 8%. You know, how much money is that worth? You know, is that a value proposition, a business case? And we have, and it's a common sense, but we still have to make that case and have the studies to prove it still.
So, yes, I'll take one more from the panel, but we do have a long list of people out there.
So I wanted to address your comment about scalability as well. And first of all, I'm always happy to talk about this, whether it's with other pharma companies, whether it's with the FDA. I don't think this is something that's proprietary to Merck. It's something I'd really be happy to see more companies do. I think some of the barriers to the scalability of this is, first of all, I think there's only 2 of us working full-time in the industry, Lori at Eli Lilly and myself.
We also have to find
Yes. Oh, yes, that also is a rate limiting factor. But there's really not much dedicated headcount to health literacy in the pharma industry. And the other thing that is, I think, even more important than that is the number one question I always get when I talk at conferences, often outside of the field, is how do your lawyers support this, right? That in my organization, legal is a barrier. And so Heather is going to talk this afternoon about how a lawyer can support health literacy. But I think that's also really a big systemic barrier that we need to educate as well to help to have that not be as much of a barrier. So, thank you.
So we have a long list of people who would like to speak, and that's good. Very good, as a matter of fact. So let's stick to a question each so that we can go through the people who wanted to speak. Darby's?
Hi, my name is Susan. I come from Baltimore, Maryland. I have a quick comment and a question for Brian. First of all, as a disclosure, I'm a hospitalist, but I did not take care of you in the hospital. So just listening to the panels and the discussion today, the focus seems to be health literacy vis-a-vis, I think, pharmacy or pharmacological adverse events. But I think, as everybody here probably knows, health literacy and its implication goes far beyond just medication adverse events. And I think Brian's presentation was, at least for me, was a lot more helpful to get a bigger picture. Very quickly, one study that I was involved in is we looked at 177 internal medicine patients that came to the hospital, and we measured their understanding on 3 domains: their diagnoses, their medication, and the procedures they did while they were admitted. And we found that less than 55% concordance between the physician's documentation and the patient's understanding. This is very consistent throughout the literature, and to let you know that 45% of our patient population had a college and above degree. So it's mind-boggling that our patients walk out of our hospitals having very little understanding of what's been done to them or for them, in addition to, God forbid, having had some adverse reaction from the medications we give them. So to me, that's a huge, sad implication of the kind of care we give despite our best efforts. So I think the bigger implication of health literacy beyond the medication needs to be also a focus. What are we doing? Why are we missing our patients, even those who presumably have enough wherewithal and understanding to grasp what we tell them? And I think one of the reasons I appreciate Brian's presentation is it goes beyond someone's education level. Maybe they're depressed. Maybe also sometimes we send patients and that we meet our patients in the midst of them being in a very vulnerable situation. They just got a diagnosis that they have Crohn's disease, or they've been told that they have cancer, and we come in and we tell them stuff. Their ability to incorporate and understand it and remember it is going to be very low. So all of these things kind of get lost in the translation, but I think it's really important to understand that health literacy is a much, much deeper, bigger problem than adverse reactions. And one last piece of this pie is for us in this, and the study we did is, procedures. When folks don't understand what's been done to them, when they go to another state and they have an emergency, they may actually sign up for something else that potentially could harm them more, such as contrast, exposure. So I wish there was a little more discussion on that aspect, but I just wanted to say that. So my last question to Brian is, the 11 points that you showed under Project Red, it sounds fantastic, and I've read your literatures in the past and a big fan, but where do you get the time? I think one of the major problems we have is, as hospitalists, as researchers, as clinicians, is we just don't have the time to do the kind of comprehensive work it takes to really make our patients understand. So could you say how you were successful?
Yeah, so it's a terrific question. Somebody looked at how much time we spend, teaching people what to do to care for themselves when they go home. It's like in the range of 6 to 8 minutes. If the intern and the nurse and the case manager and the attending and the residents all together, that's all. And then if you think about this concept of the post-hospital syndrome, these people are in the hospital, so they've been sleep deprived for sure. They've been on narcotics. They have pneumonia. They're hypoxic. They've been in an operating room. They're taking all these different things. So they're not on the top of their cognitive game. And we go in and spend 6 minutes and we talk about this many medicines that are this long that have 2 names for these diagnoses. It's crazy. It's magical thinking that we think that people are actually going to understand. So we should assume that they're not going to, because they don't. They really don't. So that's why written materials are really important, and that's why patient caregivers are really important, and materials for both the patient and the caregiver that they can actually understand are essential. And why we aren't doing it, I don't know. It has to do with some of these things. But some of it is on us, too, because we're not really spending the time. One project I'd like to see done is re-engineering the hospital ward, and stop doing the things that are not evidence-based. And that's why we really wanted to do an evidence-based trial, say, if we do this thing, does it really work? Before we start saying everybody should be doing this. So there should be evidence. Do the things that are evidence-based and stop doing the things that are not evidence-based. We have some people may know that we put together a information technology system called Louise that actually teaches the after-hospital care plan. It's an avatar-type system. We could talk about that some other day. But when we did 158 patients with Louise, and at the end, we asked, who would you rather get your information from, a doctor or nurse or Louise? And a doctor or that Louise beat a doctor or nurse 2 to 1. And they said, why? So we had qualitative research going. It's always the same. The doctors and nurses are always in a hurry. They don't spend enough time, and they're really, really busy. And that was the question that you had. So that we need to, but it's okay. So we need to use all these systems that are being developed, because we're never going to have time, really, to do that. So we need to develop some systems so we can give the appropriate information to patients at the time that they need it in a way that they can understand it. And those systems are being developed now, I think.
Wilma?
Hello. I have one question in 2 parts, if you'll indulge me. So for Brian, Laurie, and Steve, my question is, as you move forward and you continue your work, what considerations are being made to include the deaf and hard of hearing communities and the limited English-speaking proficient communities? And then, Charles, my question to you is, wearing my interpreter hat, as Donna mentioned, when I'm given information to convert, I can't change what the doctor has said. Yes. And so if you could provide some information on how is the system that you have developed, how does that partner with the interpreter? Because I wouldn't want folks to think that this is instead of, as opposed to in addition to.
I think this is an evolution, right, is the honest answer. And so we're continuing to refine. So to be honest, I don't think we've had anyone from the deaf community in our research yet. But it's a really good point that we need to not only be thinking about respondents with limited health literacy, but also about segments within that population who are at greater risk. I completely agree. In terms of the limited English proficiency, we have had a number of people with English not with their first language. That's the closest we've gotten. So I think it was a pretty big step forward to make sure we're including limited health literacy, but this is absolutely an evolution. Every time we do this, we're learning. So I think there's a really great post that I will certainly take back and continue to include. Thank you for posting them.
And from the label standpoint, the USP standards do include mention of dealing with people who are visually impaired or are hard of hearing. And it's a real big challenge because in order to solve that problem it's expensive for an individual pharmacy to put in some kind of systems that do that. I mean, obviously there are things like medicine bottles that will, play a digital recording, but it's expensive. So at this point in time, we've chosen to focus on the things that we can accomplish, and as we look at phase 3, look at some of those other areas and hope that there's some way that we can make a dent in some of those things, or at least use the opportunity to explore what the systems are being used currently out there in hopes of spreading the learnings to other pharmacies that they may be able to benefit from.
Yeah, after presentation, when someone came up to me and said that one of their family members was in the hospital, and above the bed was a big sign that said the patient is blind, so that the nurses and all the staff were really terrific in explaining things because the patient was blind. But when it came time for discharge, they came and said, here's all your discharge paper. Because there was no really alternative system for that. Our Louis system actually is because it's verbal, and they can take a CD home, they can listen to it, and then they can touch the screen, they can respond to it, and then they can take it home and listen to it again. And there are some companies around that are developing verbal discharge instructions that have been described and I think are successful.
Something of the 12th element of RED have you
The family caregiver.
the team language assistant?
Yes, right. So in our in Cindy's toolkit, there's the 12th element of RED is language assistance. So there's a whole tool on how to assess and to deliver discharge information for people with various limitations.
Jennifer?
Good afternoon. Oh, we had something else?
I'll address the second question real quick.
Okay.
So in terms of how this fit with oral interpretation, when we started the design, I'm a really strong fan of interpreters and translators and cultural competence in the healthcare space. And one of the things that when I talk to interpreters and managers, they really want to stay on the floor and talk to the patients, and they really did not like going down to the pharmacy and hand translating documents for patients and spending 30 minutes. So to the degree that, if there was a patient, all this material was pre-printed and the interpreter could go over what was on the document that the patient could take with them, this was designed to complement oral interpretation and not to replace it. If an on-site interpreter is not available, this still works with telephone interpreters. But, as I mentioned before, trying to do demonstration via telephone interpreters is impossible.
Jennifer?
I'm Jennifer Dillahay with the Arkansas Department of Health, and Arkansas is a very rural state, and it poses some problems that we don't experience in some of our urban areas, and part of it's hospital access, and so when people get discharged from the hospital and they go home, they're really at quite a distance, and so how do we follow up? So some of the things that we've considered have been better linkages with the local primary care doctor so they can follow up, but also community paramedic programs as well as home health. And I know we've had limited time. I wonder if you all have had some experience with that and what your thoughts are in terms of that medication adherence, using those as resources to reinforce that.
I'll mention something real quick. Hey, Donna. So I also work with a group called WEDI, and the issue is the portability of the medication list across transitions of care. Mm-hmm. So if you get discharged from a hospital, how does a primary care provider access all the changes? And if you come back to the hospital, how do they know what was updated in an outpatient setting? So, Office of National Coordinator is working on a universal or a centralized up-to-date medication list by working with EHR vendors and being able to call those real time from lots of different data sources, and they're still trying to figure out how to best to do that. So one of the challenges there is that we really need to incorporate a feature that allows the patient to provide input into the medication list and the home care nurse to provide input. Otherwise, this medication list is coming from EHR systems or pharmacy management systems, and they really, to be honest, they really don't value patient input. So to the degree that this can be focused around the patient is really critical for what you're describing.
I just wanted to mention too, the community paramedics thing, which you're starting to read a lot about now, is a really excellent program. I had the opportunity to do a health literacy training to a group of community paramedics, which reinforced to me that there's a pretty significant issue there and it's really important that community paramedics understand and are skilled in health literacy techniques. Because these are folks who, this is not their normal, thing that they do. This is sort of an add-on thing, is this communication that they're having with community members after discharge and all these things. So it's really important that community paramedics get the health literacy training and orientation too, because my experience was that it's not something that is really familiar to them at all.
Thank you. Seeing no more questions, I want to thank the panel very much for their extremely informative discussion.